And my name's Andrew Macann. I'm a radiation oncologist at Auckland Hospital, mainly treat patients with head and neck cancer. And I'm one of the board members of Head and Neck Cancer Foundation Aotearoa. Well, it's true that there is a group of young people who don't have normal risk factors like a smoking history or signs of HPV and associated cancer in their tumor, who present with oral tongue tumors, often quite a young age. We do see patients in their 30s and 40s who present like this. As far as what's the cause, we really just don't know. They do tend to perhaps behave in a bit more of an aggressive way, so they do tend to get treated quite aggressively, most commonly with surgery, and then we look at the pathology and decide if they need radiotherapy afterwards or chemoradiotherapy afterwards. But yeah, we still really don't know why these young people without risk factors get these oral cancers. I think in all of the departments throughout New Zealand, we have these combined multidisciplinary meetings. They run slightly differently from one hospital to the other, but as a general rule, we try and discuss every new patient with a head and neck cancer diagnosis in those meetings, and whether they are initially seen in the private sector or they're seen in the public hospital, they still tend to get presented at that MDM, or at least a very high proportion of them do. And the way the MDM, so that stands for multidisciplinary meeting, the way it works is that there's a group of surgeons there, there's a group of oncologists, so radiation oncologists, medical oncologists. We have the pathologists who can talk about what the features of the tumor are. We have the radiologist who can talk about the imaging studies that have been done. And then we often have the supportive team there as well. So we'll have speech therapists there who are kind of like a physio for the throat. We have dietitians because head and neck patients often have dietary needs during their treatment. Sometimes we'll have a palliative care person represented there as well. So it means that we can have a discussion about what's the most appropriate treatment approach for that patient. And the patient can be confident that they're really getting a consensus from all of the different people about the best approach. And it's probably 98% of the time we're in agreement about what's the right thing to do. So occasionally we'll have a bit more of, there can be a bit more of a debate. And that first decision, what the treatment should be, I mean, the two big factors that influence our decision, obviously, we want to do the treatment approach, which is going to give us the best chance of controlling the cancer. And but the second issue that we're very mindful of is the functional outcomes. So things like swallowing and speech. So we're taking into account what treatment approach gives us the best tumor outcome and the best functional outcome. And so that might be to have surgery as their first treatment. That might be to have radiotherapy as their first treatment, or chemoradiation. So it all just depends on the circumstances. Yes, it's I guess as in a lot of cancers of the head and neck area, it depends on how early the patients present with the with these cancers. So patients who present with an early tumor, which is small and hasn't spread to the lymph glands in the neck, often surgery is all that they need. They have their operation, and we look at that in our combined meeting, and we think that's all that they need. They don't need any additional treatment. And then the more advanced tumors, where the tumor in the tongue's perhaps a little bit larger, or the tumor's spread to the glands in the neck, then they often need to have both surgery and radiotherapy, or if they're more high risk, they may need chemotherapy and radiotherapy. We always tend to favor surgery as the first treatment option. So occasionally people do present with a really advanced tumor where we think maybe surgery is not the best thing, because the sort of functional issues may be such a problem if they have surgery. So we do treat those with radiotherapy and chemotherapy as their main treatment. Yeah, it all really depends on the stage of the tumor. The early ones do well. The more advanced tumors, there is certainly a risk, even with quite aggressive treatment, that they can have a recurrence. So they're monitored very carefully. We sometimes do look at clinical photos in that meeting if the patient's not there. And so that could be a clinical photo of like a skin lesion, so that we can look at what does happen is that generally patients are examined with what's called the fiber optic laryngoscope. That's that little kind of telescope that can pass through the nose, have a look at the back of the nose, the back of the throat, down to the larynx. And that's recorded on video, so that we can see the tumor, and we can see the extent of the tumor on that, and then it's that's a record which is available later on. Can be really helpful. Sometimes if you're just looking at the tumor, you can see or you can get a little bit of information which is kind of complementary to what you see on the imaging studies like the CT and the PET scan. It's basically when we're trying to define exactly where the tumor is, we take into account what we can see when we examine the patient, including things like that video, as well as the imaging studies, and so we kind of get a composite picture. So some kind of visual presentation, whether that's a photo or a video, is certainly very important. It's such a major life event for people, and things generally happen very, very rapidly after diagnosis. They come to the combined clinic. Decision is made as to what the most appropriate treatment will be, and often that treatment will start within like a 3 or 4 week window, and things will be happening in that time frame. So it's a pretty full-on time for the patient, and lots of things often are going on. They may be having dental work done prior to their treatment, or other sorts of things. So it tends to be quite a busy time. I mean, I guess part of the problem, I think, for people is that there can be a bit of information overload. When they're first seen, there's a lot of discussion about what's going to happen, and it's inevitable that they'll take in part of that, but there are parts of it that they won't remember. So later on, we will when they start the treatment, we'll go over things again to make sure they, they really appreciate what's going to happen. Our clinical nurse specialists have a real role in that window period as well between the diagnosis and starting treatment. They're a real resource who can just help in, if there's any confusion about what's going to happen or what the steps are going to be. That the clinical nurse specialists are a fantastic, and being able to reach out or for the patients to be able to contact them so that they can get a bit more clarity. But yeah, I mean, there's just so many things. A lot of people ask about their nutrition, what they should be doing, those sorts of things. That I think the challenge for these people is that there's just so many balls in the air at the one time. Immunotherapy such as Keytruda, its role currently in head and neck cancer is mainly in patients who have disease that's spread, so what we call metastatic disease, or sometimes if the disease has recurred. And in that context, it can be really effective. It does vary a little bit from depending on what type of tumor they have. So some tumors like melanoma or some of the skin cancers have quite a high response rate to the immunotherapy. Some of the more common head and neck tumors of the mouth or the throat, the response isn't as high. But if people do respond, it can be really effective. It's probably a bit less than a 50-50 chance that it will work in that setting, but if it does work, it can work very well. And the other benefit of immunotherapy is that it tends to be very well tolerated. So some patient groups, the chance that they'll benefit may only be about a 20% chance, but it's still worth having to go because, I mean, if it does work, it can be really good. Yeah, it's mainly, as I said, in that sort of advanced setting where patient's disease has recurred or has spread that it's currently been used. There's a lot of interest in trying to bring immunotherapy earlier into the management, so when patients first present, but because it makes sense, if you want to treat a cancer, it makes sense that you're trying to get the body's immune system to work with the more conventional treatments. But currently there's no real role for immunotherapy up front. So the main treatment still is surgery, radiotherapy, and chemotherapy. So immunotherapy is a bit more down the track. So when we're planning radiotherapy, we are always very mindful of making sure we spare the surrounding normal tissues as much as we can. And so part of that is done by just how we plan the treatment in the computers. We kind of work out, we get a CT scan with the patient. Normally they're in the immobilization mask we use during radiotherapy. And on that CT scan, we work out exactly where we want to treat. And then we define a lot of normal tissue structures, about 50 structures in total. So that includes things like the mandible, the jawbone, the spinal cord, the eye, the ear, and lots of other structures. So as I said, about 50 structures in total. And then we kind of have these protocols where we try and reduce the dose to those structures, and it's always a balance, really. You've got to treat the tumor appropriately, and there'll always be some normal tissue dose, and it's trying to get that balance. But as part of that, we sometimes do put these we call them a tongue depressor, inside the mouth to actually displace the tongue away from the radiation field. So like if we're treating the roof of the mouth, like the palate, it can be good to push the tongue down out of the way. Or if we're treating more of the side of the mouth, what we call the buccal area, sometimes we put this device in, or tongue depressor, which pushes the tongue to the opposite side, so it's out of the way. So they can be they can certainly have a role in certain situations, just to try and physically place the tongue away from the area that's getting the high dose. So there are very standardized approaches as to what type of surgery can be done at local hospitals, and what tends to need to go to a more sort of tertiary central hospital. So those sort of standardized protocols have been worked out. And you're right that some of the smaller tumors can be managed at the local hospitals, whereas the more advanced surgery, particularly if they need to, when you're having an operation where they're putting a flap in, so where they're sort of removing tissue and then taking tissue from somewhere else to kind of reconstruct that area, that does tend to be done in a big hospital. Some types of surgery, they need to protect the airway because of the swelling that you can get after the surgery. So they have a temporary tracheostomy. And those sorts of operations tend to be done in the major centres. Dental care is a really major issue for patients having radiotherapy. So we have a dentist as part of our multidisciplinary group. We talked about that multidisciplinary group before, and I didn't mention that the dentists are a key member of that group as well. So often when patients present, the dentist will assess them, and we try and identify if there are teeth that could be problematic down the road, and so it may be appropriate to do some dental work prior to their treatment. But so as far as the specific of after radiotherapy, so radiotherapy itself doesn't damage the teeth. But what happens is that radiotherapy makes the mouth dry. So radiotherapy does affect the salivary glands, and both the major salivary glands, you've got the big salivary glands on the side called the parotid, and you've got smaller ones under the jaw, the submandibular and the sublingual gland. They're called the major salivary glands, and they can be affected by radiotherapy. But throughout the whole of the mouth and throat, you've got as well these minor salivary glands that radiotherapy can affect. So to some extent, patients end up being dry after radiotherapy, and that depends on how big a volume we're treating. If we need to treat both sides of the throat and both sides of the neck, the patient's going to have more significant dryness long term. And that dryness can get a little bit better over the subsequent months, but they'll always have some degree of dryness. And that's a problem for the teeth, because although the radiation doesn't damage the teeth, saliva is very important for dental health. Saliva has this role sort of in remineralization. So if you're dry, you're more prone to dental decay and faster dental decay. So that means that making sure the dental work that needs to be done before treatment is done, and then in that period after radiotherapy, it's very important to have regular hygienist input to ensure that the dental care is maintained. Ideally, that should be probably about 6 months. It's one of the issues that we debate a lot. Is the fact that patients are experiencing these dental problems after radiotherapy and need quite proactive dental input, such as a hygienist, but the funding for that is still quite a problem. It'll vary a little bit around different centres in New Zealand. But yeah, I guess that's the most important thing. Once you've had your treatment, really proactive hygienist input and dental input at least 6 monthly after treatment. So yes, radiotherapy and chemotherapy both have quite a substantial impact on taste during treatment. And patients will get really quite unpleasant tastes during treatment. So really unpleasant. So that can be a real problem for people who are struggling at the best of times to manage their nutrition. The advice we're giving during radiotherapy is kind of that food isn't so much something that you're doing as an enjoyable thing. It's just food is almost like a medicine, really. You need it because that's how your body's going to get the energy to help it heal, because we're creating so much inflammation. But it can be a real problem for people with that really unpleasant taste. So generally, once the radiotherapy finishes, the unpleasantness tends to, in most people, go away reasonably quickly within a few weeks, but then you are left with a blandness in the taste, and then that just slowly improves over a period of months. So 6 months after radiotherapy, hopefully your taste will be better, but then 12 months after your radiotherapy, it should hopefully be better again. So yeah, that recovery can take quite a long time. Again, it's influenced by how big an area of the mouth and throat is receiving the high radiotherapy dose. So in some people, their recovery will be faster than others, but probably at around a year, that's going to be kind of about a baseline of where things will be, and hopefully it will be getting back towards normal. But certainly in some people, it's it doesn't return to normal. So there's a small group of people who have more significant problems with that than that. It tends to be people more with mouth who are having really high dose, because they can have a real sensitivity on their tongue, so that certain things, like particularly like acidic foods like tomatoes or something like that, can be a real problem for them, or certainly spicy things, and that can be like a chronic long-term thing. But that's the minority of people. Most people don't have that sort of sensitivity thing. They just more have that blandness that improves over time. Yeah, so the PEG tube is a feeding tube, which is a little plastic tube that actually goes through the abdominal wall and straight into the stomach. And it sounds kind of weird, but the patients who've had them, they get familiar with them, and they can learn how to use them. We tend to use PEGs if we think that the severity of the side effects from the radiotherapy are going to be a problem for quite a long period of time, because obviously you need to get your nutrition during treatment, and if your throat's really inflamed, and the whole issues of dryness and taste changes and secretions, if it becomes a real problem, then you may not be able to get sufficient nutrition. So we can look to use a PEG in that situation. I guess we're very mindful that part of the cancer management is not only treating the cancer, but it is that rehabilitation process afterwards, and things like swallowing function, trying to get your diet back to as close to normal as possible is a key part of that. So, I mean, I always tell people that they should always try and eat as much as they can during treatment. You know, we use a lot of these nutritional supplements, which are kind of like a milkshake, you know, products like Fortisip and Ensure, which are a bit easier to drink. But I always encourage patients to try and have something that a little bit more solid. You know, it might be Wheat Bix, it might be pureed fruit or something like that, even if it's just a little bit, because that kind of uses the swallowing muscles a bit more. It's sort of a use it or lose it kind of a thing. You know, I mean, I often say, you know, if you imagine you fall off your bike, you injure your shoulder, the physio is going to get you to do this physio to stop the shoulder from stiffening up. So swallowing, if anything, it's even more complicated. You know, there's so many muscles that kind of coordinate together to make swallowing work. And the radiation is just making that whole area very inflamed. So it's easy for things to kind of stiffen up. So the more they can eat a little bit during treatment, the better it is. So if you have a PEG, or if you need a PEG, it's ideally it's not that everything's going through the PEG. You know, maybe, you know, 90% can go through the PEG, but you should still try and take that 10% just to keep the swallowing ongoing. And we'll think about that 10%. It's more from a function point of view. So you're getting the nutrition you need through the PEG, but still trying to maintain that swallowing function. So if people do need a PEG during treatment, vast majority we can remove it by about 3 months after treatment. So very, very occasionally people can need to be dependent on a PEG long term, but it's quite a small proportion of people. But the more proactive you know, you are during treatment, even if you need the PEG, but the more proactive you are with having, you know, a little bit to eat and swallow, the shorter the time frame that you'll need the PEG for. In the setting where they're having radiotherapy as their main treatment, we tend to do a PET scan as the first sort of investigation. We do it 3 months after they've finished their radiotherapy, and the reason we wait 3 months is that the tumors can continue to shrink down once the radiotherapy is finished, and secondly, the throat is, you know, inflamed from the treatment, and you wait for all that inflammation to settle, because inflammation can kind of give you an aberrant signal on the PET scan. So that's why we wait 3 months to really assess how the treatment's gone. And hopefully after that kind of scan, patients will then go on to a more regular follow-up. It's quite common they'll have a PET scan and it shows something that it shows that it's responded, but it's not quite come back to normal. So we might do another scan 3 months after that. So it all just depends on the situation. Eventually, people will be getting to the point where maybe they're having a scan once a year, just as a general check. And with head and neck cancer, because you can sort of visualize the area so well, just the clinical exam as part of the follow-up which is generally done by the surgeons, that's really important as well, just to, because you can see, you can visualize the area and make sure everything looks okay.